students, this is Dr. Razook with 9 years of clinical experience and 15 national and international journals and a monogram to my credit. This is part 2 of bleeding and clotting disorder. If you missed the part 1, I will give the link below. Today we will be discussing about Biscott-Aldrich syndrome. It's an X-linked recessive disorder with severe congenital immunoglobulin M deficiency. It is seen exclusively in boys and it is a deficiency of an X-linked genetic defect in a protein termed Biscott-Aldrich syndrome protein. The clinical features of the disease are there will be a thrombocytopenic purpura, eczema, increased susceptibility to infection due to cellular or humoral immunodeficiency, and petechiae, purpuric rash and ecchymosis are the early signs of the disease. Patient unable to form antibody against polysaccharide containing organisms such as pneumococcus, H. influenza and coliform bacilli, the T and B cell abnormalities. The oral manifestations of the disease are there will be spontaneous bleeding of the gingiva, palatal petechiae are present. The laboratory findings, there will be reduced platelet count ranging from 18,000 to 80,000, prolonged bleeding time. The treatment mainly the platelet transfusion, bone marrow transplantation and transfer factor. Next, we will discuss about thrombocytosis or thrombocytopenia. It has primary and secondary. The primary causes are essential thrombocytosis are of unknown etiology, and secondary we have reactive thrombocytosis, traumatic injury, inflammatory condition, surgical procedure, overproduction of pro-inflammatory cytokines like interleukin 1, 6 and interleukin 11, elevated C-reactive protein. The clinical features of the disease are bleeding tendency, epistaxis, bleeding into the gastrointestinal tract, genitourinary tract and central nervous system, hemorrhage into the skin. The oral manifestation are spontaneous gingival bleeding, prolonged bleeding after dental extraction. The laboratory finding, we have a platelet count increased much higher, bleeding time is prolonged, clotting time, prothrombin time and tourniquet test are normal. Treatment, usually we give blood transfusion, aspirin and corticosteroids. Next is Glanzmann thrombasthenia. It is also called familial thrombasthenia. It is an hereditary chronic hemorrhagic disorder. It is an autosomal recessive trait. It is first identified in 1918 by a pediatrician from Switzerland. The pathogenesis, abnormality in the gene for glycoprotein 2B and 3A. The defect in platelet aggregation. The clinical features are spontaneous bleeding. It is equally affecting the male and the female. Purpuric hemorrhage of the skin are common. Epistaxis, GI bleed, hemarthrosis and menorrhagia. The oral manifestation, there will be spontaneous bleeding from the gingiva, palatal petechiae. The laboratory, we have prolonged bleeding time, clot retraction is impaired, platelet count and clotting time are normal. Treatment, microfibrillar collagen preparation with fibrinolytic inhibitors, recombinant factor 7A are administered. Next is thrombocytopenic purpura or Bernard-Soulier syndrome. It is a rare disease of unknown etiology. It is a qualitative defect, functional defect in the blood platelets. The pathogenesis is abnormality in the gene for the glycoprotein 1b, the defect in platelet adhesion. The clinical feature, there will be spontaneous ecchymosis, epistaxis, bleeding into the genitourinary tract, bleeding into the gastrointestinal tract, oral manifestation, gingival bleeding, mucosal ecchymosis. In lab, we have a prolonged bleeding time and clotting time. Platelet count is normal. Treatment, we have administered usually blood transfusions. Coagulation factor deficiencies, we have the congenital hemophilia A and B, von Willebrand disease, and other factor deficiencies are rare. In acquired, we have the liver disease, vitamin K deficiency, disseminated intravascular coagulation. We will see the acquired coagulation disorders. 1. The liver disease. Liver plays a major role in the clotting process. The site for the synthesis of clotting factor and their inhibitors is the liver. Liver diseases causes impaired hemostatic function. Most common finding of liver disease is thrombocytopenia. That is the most common hematological finding in a liver disease. There will be decreased platelets, that is thrombocytopenia. Clinical findings, no abnormal bleeding, gastrointestinal hemorrhages. In oral manifestation, there is recurrent ecchymosis, epistaxis, severe generalized bleeding. In lab, there is decreased platelet count, increased level of prothrombin time and activated partial thromboplastin time. Treatment, fresh fluorescent plasma, cryoprecipitate, recombinant factor 7A and thrombopoietins like eltropopap. Vitamin K deficiency, they causes hemorrhagic disease of the newborn. Now it is uncommon due to administration of vitamin K at birth. The vitamin K coagulation vitamins like 2, 7, 9, 10 and fat soluble, they are fat soluble vitamins. They are involved in both intrinsic and extrinsic pathway of clotting. The role of vitamin K, they are necessary for post-translational carboxylation of glutamic acid. They are necessary for calcium binding to the protein like prothrombin factor 2, 7, 9 and 10. The sources of vitamin K are the green leafy vegetables, butter, liver, milk and vegetable oils. The requirement, the daily requirement is 1 to 2 microgram per kg. The clinical features, bleeding is severe, it causes melena, large cephalomotomos and bleeding from the umbilical stump. The oral manifestations are the gingival bleeding, prothrombin levels less than 35% will cause bleeding immediately after toothbrushing. Prothrombin levels less than 20% will cause spontaneous gingival hemorrhages. Laboratory diagnosis, there is increased prothrombin time, partial thromboplastin time. Treatment, we administer vitamin K and transfusion of plasma. We have the disseminated intravascular coagulation. DIC is an acquired syndrome usually characterized by a systemic activation of the coagulation and results in the formation of thrombi throughout the microcirculation. The etiology is obstetric complications, infection, neoplasms, vascular disorders, massive tissue injury following a snake bite or a trauma. The clinical features, acute DIC and chronic DIC. In acute, we have generalized ecchymosis, petechiae, bleeding from previous venipuncture site, hemorrhagic skin lesions, acral cyanosis, epistaxis, gastrointestinal bleeding, pulmonary hemorrhage and hematuria. In chronic DIC, we have extensive ecchymosis of the extremities without petechiae. There will be renal impairment, neurological symptoms, Trousseau sign positive, recurrent episodes of epistaxis, serious internal mucosal bleeding and thrombosis. In laboratory, there will be a prolonged APTT and PT. Platelet counts are usually less than 50,000. Increased fibrin split products. The usual findings in DIC. Treatment, we give anticoagulants, that is heparin and fresh frozen plasma. Next, we move on to hemophilia. Disease of the Habsburg, or it is the disease of the kings. It is also termed as the royal disease. It is an hereditary disorder. This defect carried by X chromosome and transmitted as a gender-linked Mendelian recessive trait. The hemophilia are broadly divided into hemophilia A, hemophilia B and hemophilia C. A is a classic hemophilia, deficiency of factor 8, and B is also called as Christmas disease, deficiency of factor 9, and C is Rosenthal syndrome, deficiency of factor 11. In genetics, the hemophilia A is due to deletion abnormalities with stop codons or a frame shift defect. Hemophilia B, partial and total deletion, missense mutation, they result in decrease in or absence of factor 9. Hemophilia C, the mutation of factor 11. Hemophilia A, 80 to 85% of the hemophiliacs are hemophilia A. They occurs due to deficiency of factor 8. It's an X-linked recessive disorder. Females are carrier and affect males. The disease affects 1 in every 10,000 patients. For positive family history is a classical finding of the disease. The disease is seen in Great Britain's Queen Victoria, so it is also called as royal disease. Hemophilia B, it is also called as Christmas disease. It is named after the first patient in whom it was described. It is an X-linked disorder. The 14% of the patients are usually hemophilia B. Clinical features, persistent bleeding, either spontaneous or following slight trauma, hemorrhage into the subcutaneous tissue, internal organ and joints is the common feature, usually present from birth but becomes clinically apparent after several years. The classification of hemophilia, severity into mild, moderate and severe. Mild, major injury or surgery resulting in mild bleeding. Moderate bleeding with minimal trauma, and severe, there is severe spontaneous bleeding and muscle hematomas and hemarthrosis. Oral manifestation, there is hemorrhage from any site in the oral cavity is a common finding. Gingival hemorrhage may be massive and prolonged. Tooth eruption and exfoliation show severe and prolonged hemorrhage. Mandibular pseudotumor reported by Stoneman, in which there is a periosteal bleeding with reactive new bone formation causing tumor-like expansion of the bone. In lab, there will be prolonged coagulation time, bleeding time is normal, PT and platelet aggregation is normal, APTT is prolonged. Management, preoperative transfusion of whole blood, administration of factor 8 concentrate by intravenous infusion. Next, we move on to von Willebrand disease. It's an hereditary bleeding disorder, autosomal dominant disorder, manifested in both males and females. It is characterized by prolonged bleeding time. Classification of von Willebrand disease. It is classified into type 1, type 2 and type 3. Type 1, there is partial quantitative decrease of normal von Willebrand factor and factor 8. In type 2, there is primarily qualitative defects of the von Willebrand factor. Type 3, its most severe form and its rarest form of von Willebrand disease. It is characterized by marked deficiency of both von Willebrand factor and factor 8. The clinical feature, its prevalence rate is 0.9 to 1.3%, so it is a rare disease. Many children are asymptomatic and are diagnosed as a result of positive family history and excessive bleeding. The sites of bleed usually involves the nose, skin and gingiva. The oral manifestation, gingival bleeding. In some instances, there is spontaneous bleeding, and other cases bleeding occurs as a result of brushing. Lab, we have increased bleeding time. PT, clotting time and APTT are normal, and positive tourniquet test in 50% of the cases. Management, usually there is transfusion of plasma and anti-hemophilic factor. We can also administer desmopressin. Summarize, the bleeding disorder, we have seen the vessel wall abnormalities, qualitative disorders of the platelets and quantitative disorders of the platelet. And in clotting disorders, we have seen the congenital disorders like hemophilia A and B, von Willebrand disease, and in acquired, we have seen the liver disorders, vitamin K deficiency and disseminated intravascular coagulation. This leads to the end of today's session. We will see in next session with another interesting video. Thank you.